I'm on nothing. I'm today. You're on something. You're stuck with the sorry.
Go. I was about to say there was a line at the women's head, so. I mean, no, you don't understand. It does take us longer to leave the head. Throwing that out there. All right. Hopefully I can run this thing. Should. Yep. Okay. So I guess like just a couple things that I thought about after the last bit of the like e-profile 3822 stuff. You guys asked wonderful questions because I know like for the interns, this is, you know, drinking from a fire hose, right? This is stuff that you guys haven't seen very much, and all of a sudden we're like, you need to be doing this stuff. And it's just like blows your mind. But it's good that you're learning this stuff now, because I will say, when I was an intern, so I did my internship in medicine, and then I escaped. So I did my internship in medicine, and a lot of this stuff, like obviously the behavioral health stuff we didn't really talk about. They were just like, oh, send it to psych, we don't want to touch that. But I learned how to do like, you know, Lindu's like duty just for like physical limitations. But then when I became a flight surgeon, it was a trial by fire, and I had to learn by myself. And I'm sure like the other female in the room like understands the same thing, right? We didn't necessarily learn it while we were sitting here as interns, and all of a sudden they were just like, here, you're expected to know this stuff. So it's good, and that's part of the reason why we're teaching you now, is so you learn these things and you become more confident and more comfortable doing it, so that if any of you end up going off into operational medicine land, which is really fun, and I highly recommend it, then coming back, right, you Lindu. So Lindu is light duty chits. If you guys saw the presentation last year, this is going to be very similar because I used the same slides. I only made a couple updates because there was a change in the instruction in the interim. So what am I going to talk about? So I am going to talk about Lindu. So like, what is a Lindu? When do you place people on Lindu? How do you place people on Lindu? How do you get access to the system, which is already kind of touched on before. Light duty chits also I'm going to touch on. I'll talk about what they are, when you put those on. Things I'm not going to cover today are the referral to med boards, to the IDES system, which is the disability evaluation system. And then we're not going to talk about ADSEPs today, but obviously this does interplay quite a bit, okay? All right, so we kind of talked about this stuff before, so I'm not going to rehash it, but our job as military psychiatrists is not only to take care of our patients, it's also to take care of the mission. And sometimes those things seem like they're kind of mutually exclusive, right? So it seems like we can't take care of both things at the same time, but you have to learn how to kind of balance those pieces equally. And so we can take care of our patients. I like to sell it. I mean, doing this by the past year, right, on outpatient, I have had patients that come in and they're like, doc, I really don't want a profile. I really don't want to do these things. I don't want to seem like I'm weak or I'm not able to do these things for my command. But after a discussion with them, you have to sell it to the patient as, I am taking care of you by putting these limitations on you because it's allowing you the time to get appropriate treatment, to continue your care. And your command is not going to hound you for all of these things, right? In the interim, they understand that you need certain things, and we know that you can't deploy right now. So that's ultimately like, can we send this person who's very underway, and do I trust them to be sitting behind me in, you know, a foxhole somewhere with a gun, right? Ultimately, that's what you have to be thinking about every time you see these patients. And I know it sounds like weird because, especially going through medical school on the civilian side, doing a lot of civilian rotations, you don't think about that stuff, but we have to. So that's why it's important. Okay, so this is kind of a standard bread and butter kind of Lindu case, right? So you have a 22-year-old single female active duty petty officer, no medical history, no past life history, came into 7 West after a suicide attempt. And so after you get them stabilized in 7 West, you send them back out to the outpatient land. And what do we do, right? So things that we're thinking about when we're evaluating people, and this applies on the Army side and on the Navy side, right? So if you don't expect them to be able to return to duty, which will require an automatic like IDES referral, that's only for a couple of very select diagnoses. Does anybody know what they are? I guess we'll start with the interns. The interns know what they are. Choose? Bipolar 1 and schizophrenia, right? So like psychotic spectrum kind of diagnoses. So schizophrenia and then bipolar 1 are those diagnoses. If you expect that they're going to be able to possibly return to duty within a 6-month period, then that's when you put in a Lindu recommendation for them. If you think that it may not be as serious, right, or may not take as long time for them to recover, and depending on the condition, you can also do a light duty up to 30 days, and you can do up to 3 of them in a row before you would have to place them on a Lindu. This is, I'm not going to go through this whole thing. We're going to cover this stuff, but this is the algorithm that's in the instruction from the ManMed chapter 18, which is what covers all of the Lindu stuff. If you want to take a closer look at this algorithm, that's fine. I'm going to give you the simple marine proof algorithm. So this is for you, Tom. I know, you made it. I updated it, but so if they are requiring duty limitations, like will they resolve within 90 days? Yes, great. Then you can probably do a light duty check. We'll talk about when you would want to maybe do a Lindu instead, even in that situation. Is there an anticipated return to full duty? Yes, then put them in Lindu. Or is it going to be greater than 12 months that they won't be fit for duty? Or does the condition require an automatic MED referral? If yes, then you go to the like MED automatic, do not pass go, do not collect $200, the end, right? Okay, so a Lindu is a documented period of medically restricted duty that allows for treatment. Same thing as a profile, right? They're not that different. It gives the same recommendations. The period can be up to 6 months. So this was a recent change. They used to be an automatic 6 months. It's not like that anymore. So you can make them shorter periods of time. However, the instruction still doesn't reflect that. And so it still says like if you have 2 consecutive Lindu periods, and it adds up obviously to a 12-month period, because per like the Department of Defense, right, you need to be readmission capable within 12 months. If you are non-deployable for greater than 12 months, obviously other than certain circumstances like pregnancy and childbirth, then you can, you have to go to a med board, basically, is the like DOD hard line. So that's where this comes from. So if you have more than 12 months or greater than 2 consecutive Lindus, like 6-month Lindus for the same condition, it's going to require a medical board referral. And that doesn't necessarily mean they're going to get out as a like medical retirement, but that does require a med board referral. So why do we place Lindus? If there's a condition that appears to significantly interfere with their ability to perform their duties, if you feel like they will be able to come back to full duty, and if the significant illness or injury necessitates ongoing care to maximize benefits, so that maybe they will benefit from treatment and improve to a certain point where at the end of that period, they'll be able to return to duty and go back out into the fleet. All right. So the other thing that Lindu does that I don't think is the same with the e-profile system. So the Lindu system will tack on a specific code, right, to the sailor in the personnel office, right? So that way, PERS are people who assign us to billets and figure out who goes where and when they get to rotate places, right, or move. It taxes code onto them so that they are not able to PCS, and so they're not able to get tagged for deployment. So it serves an additional administrative function other than just, communicating to the commanders that their soldier or the sailor or Marine is not able to do their job, right? And I will say too, the Lindu system does not automatically send a notification to the commanders. You have to notify the commanders. So that's different than the e-profile system. All right, so I will say just like a caveat to that is like I have moved I had PCS a sailor to a new command while they were in a Lindu status, but it's only in specific certain circumstances, in this case, like a sexual trauma, to get them away from the perpetrator. So that's kind of one of the few times where you still can move somebody in that Lindu status. Otherwise, it's going to put a hard stop on them PCSing anywhere. All right, this goes, I mean, they just showed you this information before. It's on the website. So you have to go through the training, which is on Elias Health. For Walter Reed. And if you happen to go to one of the other sites like Fort Belvoir, or if you're rotating there as a third year, right, as on your outpatient rotations, they will like map you basically using your access to their hospital as well. All right, so how do we do it? So this is the Lindu website, and I will say like all the instructions, like frequently asked questions, user guide, all of that stuff is on the Lindu Smart website. So if you have questions, in addition to the ones that are on our website, right, the Lindu Smart website has all of this information there too. So when you go into the Lindu system, you'll get to this site, and then you just basically search for a sailor. If you don't have them already on a profile, or they don't already have a Lindu in there, you need to add them. And so you basically select like enter new Lindu personnel, and then a blank 6100/5 form will come up. If they're already in Lindu Smart and you have to put another Lindu and a new like Lindu in there, then you still would say like enter new 6100/5 with the service member. So these forms, honestly, very similar to what you would see on the profile. It's just kind of put out in slightly different words. So you select the branch that they're in, whether that be Navy or Marines, proposed start date, proposed end date. So the longest you will be able to put it on there for one period is 6 months, but you can make it shorter than that if you would like. So if this is their first Lindu period, obviously it will be their first one. If it's a subsequent Lindu period, like then you'll pick the second one for the same condition. If it's for a different condition than their first one, then you would select obviously accordingly, and the system will kind of auto pick which one it's going to be for you. Pick the right diagnosis. It's based on like ICD-10 diagnoses, so when it's in the drop-down box, so you just pick the right diagnosis as the primary limit, and then put in the limitation. And then, so the limitations are kind of checkboxes similar to the stuff on eProfile. And the last section will be the overseas or sea duty assignment. So basically what I always check are no shipboard duty, no deployment or overseas duty, no field duty, no combat duty. And then the second part is that and I will say like Lindu doesn't auto-populate the blurb, so you have to populate it in there. So this is basically the blurb that like we took from what's almost exactly the same as on the eProfile system. You populate that in there, say, that they're entitled to deploy, literally like plug in the treatment is expected to occur every how often. You can be as specific or as not specific as you want. So if you have multiple providers taking care of the patient, like Dr. Lehman and I were just talking about this, like, for instance, I don't put in there like how often they're going to follow up with their therapist, because I don't know, they may follow up every week. They would probably, if I'm doing medication management, they only follow up with me once a month. So I will just say like, but treatment will require them to attend like regular behavioral health appointments for, as determined by behavioral health providers for X amount of time. In this case, 6 months. During that period of time, say what limitations they get. So don't have them handle munitions, don't have them attend any live fire drills, ranges, or combat simulations. And then kind of any other additions that you think are appropriate. And I'm not going to rehash what you talked about last block, right? Because we just talked about that. So things like ensuring they get adequate rest periods. If you feel like they shouldn't be doing 24-hour watches, you could put that on there. But again, these are meant to be temporary limitations unless you're putting in their third Lindu period to trigger a med board referral.
Sometimes that really matters.
Yes.
I've had commands ask, well, it's not on the list, so
Yeah.
And again, these are recommendations. You can try to say this is how many hours a week, or this is the time frame I like to work, especially if you're trying to get to sleep, not for the night shift, but just sometimes being a little bit specific and then allowing them to figure it out. Feedback would be helpful rather than making the assumption like, oh no, they need sleep.
Yeah, and I will say like some of that depends on kind of their, and in the Navy we don't call it MOSs. It's your rates. So certain ratings and certain jobs, right, do require certain times of crew rest, right? So like aviation is a great example. That's the community I come from. Some others in the audience do too. So like we'd have required like crew rest periods. Other jobs don't necessarily have that, and they're very different depending on what your job is. So knowing that piece too, and knowing kind of what their job entails, helps you kind of make more appropriate recommendations. So I will say like one of the most important things that I learned is to spend time like if you're on an operational billet, right, spend time in your operational environment, get to know what they do, what their jobs are, and that will help you make better recommendations. It also helps the commanders get to know you and be able to trust your judgment and your recommendations. And follow on with like what you're recommending, because ultimately, just like Dr. Suprico said, and that's one of the hardest things you may need to learn in military medicine, is that most things that we say are only recommendations. The commander does not have to do them.
But yeah, I would say,
Yeah,
I would, from my experience, I would say 99%.
they usually do.
They do, because going against medical advice, it's because there are liability. So, we respect the authority that they have over a lot of responsibility over their service members. But we want to be the subject matter experts, and they generally do default to that.
Yeah. Assuming they know that you make like reasonable recommendations, because they will say sometimes like, Doc, that's really not, that's not doable, that's not reasonable. So you have to know, again, like some of the limitations of that. So when you put everything in there, you'll select the correct like MTF. So if you are mapped to multiple MTFs, so like I'm mapped both to Fort Belvoir and to Walter Reed, make sure you pick the correct one, or else you won't be able to route it the right way to the right people. So pick the correct MTF, and then there will be an option to pick whoever your second signature is. This is going to be whoever your attending is. And then make sure you click sign form. And then make sure you get the little green box that says form successfully signed, because you can save the form in Lindu Smart and not actually submit it. And that would be a problem. So make sure you get the signature thing that says that it's actually signed. And then it'll get routed to your attending. Yeah.
Is there a third signature, like usually like your PDA chatter, like or we got
Yeah, that'll be the command authority, so the CA.
So here on the wall, that's the media authority.
Yep.
For the second signature, when you become attending, you may share a case with the psychologist. That could be a second signature.
Mhm.
But if you don't share the case for some reason and you're doing both medication and therapy, then you go within your directorate to find a colleague, maybe it's the supervisor, psychiatrist of the outpatient clinic, and say, hey, you need a second signature in this case. Because you're competing with authorities, not people. So you need to reset this.
Yeah.
Do we use our global supervisor? Or the second?
Yeah, so like whoever your attending would be, so like on outpatient, it's going to be whoever your global supervisor is. Yeah, because they'll be the one who's basically supervising you on the case. Yeah, and then the convening authority is determined by the command. So But that's why I say you have to pick the right drop-down box for the right place, or else you're not going to be able to pick those people, right? Yeah.
So when you said the system is automatically accounting for multiple Lindus,
Correct.
is it still keeping it within the total 12-month period, even if there's ones for different conditions?
So if it's for different conditions, like you have the option to pick, like, for instance, if it's their third Lindu, but it's for a different condition, then you have an option that says on the 6100/5 form, like, this is a third Lindu period for a different condition than the other two. So you have the option to do that.
So they're not combined.
Correct. Yeah, so it's not gonna then like tack it on and be like, this is, all the same, because say for instance, they got one for, like, I don't know, breaking their ankle or something, right? They had a Lindu for that, and then, we'll put in the one for behavioral health. It does take that into account in the system too.
Quick
Yeah.
question, you mentioned that the first one they were made second less than 6 months.
Correct.
Is that second Lindu or 12 months stricter?
So it's supposed to be 12 months. But I will say, like, currently the way that the system is still designed, it defaults to when it picks the third Lindu period, that it will try to automatically go to an MEB. That they haven't kind of updated the system to match what the new regulations is yet. Yeah.
So in that case, would there ever be a reason to not do something else for 6 months?
Yeah, so I don't. I usually just go ahead and put 6 months, and you can always return them to duty right before that 6 month period is done. Right, so there's nothing saying that you have to go the full 6 months. If they get better in 4 months and you can return them to duty, then do it. Right?
Would still provide that window.
Correct, and still provide the whole 6 month window in there. Yeah, Chelsea.
In Lindu Smart, how would you like physically return them to duty? What do you have to do that?
I don't remember whether that's in the slideshow or not, but I'll talk about it. So on Lindu Smart, same thing, like, you'll search for the service member, you'll find them, and then you click on them. There's going to be a like Lindu, like, there's a return to duty like button, right? And if you populate I believe it's 6100/6 form. I think it's actually maybe on the next slide. And that's how you, yeah, so profiles, right, automatically expire. I don't know if I mentioned that last time. Profiles will automatically expire. Lindus do not. You have to return them to duty. So you'll fill out a 6100/6 form, and then, which is in Lindu Smart, and that's how they get returned. And same thing, right? You'll keep the same like signature people and everything to return everybody to duty, right? You do that all within Lindu Smart. The 1300/3 form is a different form that basically is for like operational duties, like saying you can return them to operational duties, and it says like any required follow-up after their Lindu period, but it's not included in Lindu Smart. It's like a separate form.
And I've seen this at multiple sites, when someone's being returned to duty, or, I mean, the profile is automatically expired, but there's just verbiage that people add. So whatever stipulations you put on for their Lindu that they couldn't do, in theory, once they are returned to duty, they should be able to do all of it. Different things, different duties. So not, they can do all of this except go on separate because of question. Like, these are real things that I see, but, and it's not just this site, it's multiple sites, but fit for full is full in general. So unless you think they need more time observation of the medical boards to determine can they be fit for full, then fit for full is the expectation with their return to duty.
Yeah, and obviously, like, that's going to be like Dr. Subrigo just said, that's kind of dependent on what their job is. So like for your general Marine or sailor, that you're saying like they are fit for full like general like military duties as required by their specific rate. Because you will have people, right, that are not able to continue to go on submarines, right? I have one of those, so they can't go on submarines anymore. So I did have to fill out the stuff disqualifying them from submarine duty, but they can do everything else, right? Like, so they happen to be, a yeoman, in which case it's like doing administrative stuff in the Navy, right? So they can do that job, they just can't go on a sub anymore. Or say for aviation, right? Like, there's a lot of additional things that you need to be, a lot of additional like certification qualifications, right? That you need to be able to meet that are above the general military standard. So for the special duty situations, you can always say like, yes, they can return to their duties, but if you have to disqualify them from some of their special duty stuff, you need to work with like their dive officer, their flight surgeon to make sure that they get disqualified from that other stuff. So that's, and a lot of times on the Navy side, at least, like you as a specialist, yes, you communicate with their command, but especially if they're in special duty situations, like you will communicate with their flight surgeon, you'll communicate with their undersea medical officer, you'll communicate with like whoever the primary care like battalion surgeon or whatever is that helps take care of their unit, right? Like you communicate to the other medical personnel as well. Because it's their job to sometimes determine the fitness, which we don't get a lot here because we don't have a lot of operational needs here, but yeah.
Would there ever be a reason to go from the 6 months and say they're getting mostly better, but still want a couple of limitations? That would like, should that ever happen?
Can you also repeat the question?
Oh, so he asked if there's any reason why you could do like a Lindu and then say they're mostly better, but still have a couple of additional limitations, right? That you want to still put on and you just basically do a light duty after that. If you're returning them from a Lindu, like they have to be fit for full duties. Like that's part of what you're doing when you submit the form.
Because that
So-
could become frustrating to the command and
Yeah.
it's like, oh, they returned to duty, but now they're going on a light duty. I don't understand. Versus the Lindu.
Yeah.
Do another.
Yeah. If they're still sick enough to need continued limitations, right, then they still have continued limitations. Yeah, because if you're basically like using the light duty as a step down, like it's not going to work out very well. Command's going to be frustrated. And the other thing is, right, depending on what those limitations are, because usually one of the primary limitations that we're going to want to say is like they can't deploy or they can't, go to an austere environment. If you're saying those things, they need to still be on a Lindu because a light duty chit is not necessarily going to prevent them from doing those things. Because a Lindu will.
Yeah, I'll caveat that too. So more so a Lindu is kind of almost a directive towards the command to say like, hey, this person is no longer part of your personnel or is not a full duty. And so a light duty chit is more so a recommendation to them. They do not necessarily.
We'll cover that in a second.
Oh, you were gonna talk about that?
Yeah, I'll talk about light duty. in a
Yeah,
minute,
yeah,
but- Yeah. Yeah.
If you do a review for 6 months, and that 6 months is now ending, do you have to physically return them to duty with the button, or does it just expire and then?
No, it doesn't. You have to return them to duty using this.
Do we get like notified or pinged that one's about to expire? Or do we just have to?
So at Fort Belvoir, we do. Our HM1s at Fort Belvoir are awesome and ping us like a month out usually from when their Lindus are about to expire and ask like, are you planning on extending this? And if you're going to plan on extending it, they'll usually honestly do it for you. And it's wonderful. And if you plan to return them to duty, they'll be like, okay, doc, like let's go ahead and do that. So I don't know what happens on the Walter Reed side because I haven't done it over here.
On the side, usually it's like matter of stuff, so it's gonna send you an email.
Yeah.
I mean, sure. The convening authority to work closely with the case manager or some sort of like your case.
Yep.
Go to regular meetings and have a stack of cases and start signing off. Return to duty, continue, do receipts, medical board, and so based on that, that's will get dispersed to the providers.
Yeah, so there's usually like a Lindu office, there's an MEB office, like at any of the big like hospital centers, like they're gonna have that, even at the smaller clinics, right? They'll have a like Lindu office and they'll have people overseeing all the Lindu personnel and everything. And so they usually ping the providers and say like, hey, what are you planning on doing with this person? It's getting kind of close to the end of this Lindu period. What do you want to do? So they do ping you. I'm a little obsessive, and so I keep a spreadsheet of my like outpatient patients and have like it written in there when their stuff's gonna expire, so I keep track of it too.
There's a uniqueness about putting someone on to homeless versus overseas, because a lot of times when I was in residency and I would think on Lindu, they would get restationed to the hospital, they would be closer to the hospital, get some sort of, low optimal job to work in the hospital versus overseas. You weren't medevacing with that. You could end their tour a little bit earlier, but that's a different process. So if you're just putting someone on Lindu overseas, they're still going to remain overseas. They're still working at the command. So it's so that much more important to really explain to the command. I know they're going to be there physically, but they can't be doing that same job necessarily. And that's part of those limitations. But it's easier to do that obviously when you pull someone from the command versus
Here at Walter Reed, our people usually stay with their units. They don't get pulled to the hospital. That happens at Portsmouth, but that doesn't usually happen here at Walter Reed. It's very, very rare. It's usually only the people that go are maybe going towards an MEB, like they'll try to get into like the wounded warrior unit or whatever. But yeah, we don't pull them from their commands. They still stay usually with their home units, just like it happens overseas. Anything else? Yep.
This might be something that I missed in the conversation, but given that you have this, like, first budget expires, like you were on the engagement happens.
Yep.
What occurs if that doesn't happen? Like, does it automatically turn into or? And it's like, what is the repercussion?
I will tell you, like, you will get pinged by somebody to like make something happen, and they will ping you repeatedly. So they'll usually ping about a month out, and then as they get closer, they will ping again and again and again and again. Be like, what are you doing with this person?
Because the competing authority meetings, we end up, meeting with the CEO of the medical records, and so, the other providers who are in charge of the other specialties and track kind of the high interest cases, but also, again, kind of assess, so whoever is on that team knows track those cases, right? Hey, this person is about to expire, what's going on?
And the command will know as well, they'll recognize that someone.
Yep.
Usually there's one tracking all of it.
Yeah, there's usually attached to like each command, they usually have somebody for like medical readiness, right? That's like tracking all the people that like haven't done their dental and haven't done their medical, because that used to be me. I'm sure that used to be you too. So like, you know who on your unit has not done their stuff and who is, has a certain code attached to them to say they're not medically ready and why that is. And so you track those people too. So there's always somebody attached to the command that knows those things too, and they'll ping you too. All right, I think it was Zach and then,
I think like, especially for interns, like it's very useful, like the fact that you have to return to duty, every active duty service member in the Army, they admit to 7 West, will put a profile on, but we will not put a Lindu on preliminary outpatient because we won't see them in 6 months. We won't know if they're ready to go back or not. So that will be up to their we typically email their outpatient provider, let them know what our recommendations are. But 5 or 6 months from now, they may be ready, or they may not be, but it will come back to you. So that's why we don't typically place a Lindu while they're still on 7 months. But we do place a profile.
yeah, I think I will say the caveat to that is like, it kind of depends on why they were admitted to 7 West. Because for instance, like if your person's admitted because they attempted suicide and had a pretty serious attempt, right? They are not going to be deployable for 12 months to like anywhere, right? So, and that's based on the like COCOM guidance. And maybe at another point, like maybe when I'm STR, like we'll go over that kind of stuff and talk about like deployment screenings and that kind of stuff. Because I don't think we've covered that at any point for any of the groups. So we can go through that stuff at a different time. But in that kind of situation, like, yeah, you should still put them Lindu, and then it'll be tracked by like whoever kind of they belong to, whoever they're primed to, basically, will track that. And they will ping, providers. And you can just say like, if they ping, the person who placed it while they were on inpatient, like it is up to their outpatient provider. But I think too, like it consistently reminds you, like, since it's not going to expire, it consistently reminds you to think about this every single visit you have with these people. So, and to document appropriately. And so there was something about like documentation, like your communication with command, as well as your recommendations. So for instance, at the end of our like Fort Belvoir notes, we have a whole section on like military readiness. And it's a bunch of check boxes. Like, do we think they can deploy to an austere environment? Yes, no. Do you think they can handle weapons? Yes, no. Can they have a security clearance? Yes, no. Are they are they on temporary limitations? Have we reached the determination point that they need to go to a med board or to an ad step? Are we going to return them to duty? And it asks all of those things like on checkboxes at the end. And the last section is about communication to commanders. And so it asks like, what date did you communicate to the command about these recommendations above? So that's kind of one of the ways that as we're going through, like based on the instruction, you're supposed to document when you talk to commanders. And I always like put in a blurb in my note, like if I talk to the command, like, because I always get information back from them too. So just getting into the habit, especially on your outpatient year, right? If you communicate to command, what did they say? What did you guys talk about? What are your recommendations? And put like, yes, they're in agreement. They're not in agreement. Here's what we had to talk about to make changes, right? So documentation is key, because especially in one of those situations where they decide maybe not to follow your recommendations, you need to document that this is what you recommended, X, Y, Z, and they decided not to go with that. So just in case there is an adverse outcome, right, legally speaking, you also have everything documented in your notes that this is your recommendation. And then they then are taking on the risk if they choose not to agree with you. Make sense?
So about following recommendations, you were saying that commanders will follow our recommendations like 99% of the time.
Yeah.
I was wondering if there's anything usefully generalizable about that other 1%.
No, it kind of, yeah, it kind of depends on like what their duties are and some of the mission requirements for them. And it depends, like, I guess, so for instance, there in one of the operational sims, which is similar to a situation that I had, is that, you know, we had somebody who they were doing a mishap investigation, which for a mishap investigation on the aviation side, like you have to get that completed within a certain number of days after that event. And so the command is going to be in a high op tempo time. They're going to have a bunch of people like doing a bunch of things, right, and completing their jobs so that the commander can have everything back to the powers that be, right, with the whole determination, right, at a certain time point, which is step 2. And there was only one person at the command that could do a specific job. And so, you know, they had been recommended a Lindu with certain limitations, but because they were at N of 1, it was the only person that could do this job. Like they still had to do some of those job duties that maybe we wouldn't have liked them to do and required them to work a little longer hours than we would have liked. But they still had to do it because they were the only person that could in this situation, based on like operational requirements. And it does depend on like severity of the case too. So you can say like, okay, well, this person probably can still handle it. I guess we can like make that concession, but there may be some cases where you have to push stronger depending on the situation. But I think it's very situation dependent for that last kind of 1% in my experience.
Yeah, no, it's very similar, but like, for instance, overseas, one of the big questions, dialogue with commanding officers was, does this person need medevac or not? And some were all for it, and some were all against it, depending on the person, what they did, how many they had within that radar and all that. And so sometimes, you know, where I thought yes, they thought no, and vice versa. And sometimes we were in agreement. But at that point, for me, it's getting leadership involved, your leadership involved in that conversation, because depending on where you're at, you know, however that gets looped back around with this stuff, like you might have a conversation with the CO, and they may reach out to the CO of your commander, and that CO reaches out to your DPH, and the DPH is contacting you saying, hey, what's going on in this case? Just be proactive and say, hey, this is where we're at, you know, this is what I feel about this case. Usually at the hospital, there's some sort of kind of staffing that you can do. If there's not a formal group, you can go to colleagues and say, who have maybe been there longer, and say, hey, what have you historically done or seen in these type of cases? Am I really, you know, off in the field right now, or is this reasonable to be recommended? And especially if you have support of your leadership, no matter how kind of hard pushback you get, you know you're going to have kind of global support in the hospital that your representative understands, you know, whatever it is that you're representing. And to me, that's moved over a lot more situations that could have unnecessarily escalated.
Yeah. Don't be afraid to phone a friend.
Yeah, and I hear a lot of people asking about like, when am I going to get things, will the command ping me, will the hospital group ping me? One thing that I find helpful, so that you don't have to memorize it, or like put it in a secret section, or have a bunch of charts where your links are at. I like to just mention in my notes somewhere, not only like, you know, checking a box or a PhDP thing that's like, yes, they're on Lindu, or no, they're not. But I try to say initiated on Lindu as of December 2021.
That's what our notes have. It has a section like where you put the date that you put the profile Lindu in.
Yeah, so then even if you're, you know, not tracking amongst all your patients, you can look at your note and be like, okay, like, may have not started to be on this exact date of like 18 December, but took a few people to sign off on it by the 21st of December, but at least you have a general time frame of like, okay, December, you know, like 6 months out, and then go with it.
Yeah.
Do Lindus reset in between each other? Then you get reset and then you would have another 12 months for that member, same condition or different one?
It depends on like if the situations are the conditions are linked or not. So like for instance, if it's like an adjustment disorder, then they're basically like very discrete periods of adjustment disorder, right? So it was an adjustment disorder to like this specific situation. They went like 3 years and didn't have anything, and then, you know, another episode. So the system won't actually automatically reset it. It'll basically like track it as, you know, a second Lindu period. If it's the same diagnosis, right? It'll track it as a second one, but then you can put in your verbiage saying that it's like a third one for a different condition. and then, you know, if you get to that point. But yeah, the system is not smart enough to recognize that it's like discrete periods.
And how we're training these people is like in the, say, 20 or 30-year career period that you have, for the same specialty, you're generally going to be granted 2. Obviously, life happens in between all those years. So if you translate it to orthopedics, someone might break their ankle the first year of service and then their 15th year of service, and or period of review based on the recovery that they need. So same is true for mental health in that aspect. But we sometimes see requests for a 3rd period of review for the same condition, and at that point, you know, it's just or if it's even if it's like spaced out a little bit, like 6 months apart, then it's still the adjustment to sort of carrying over.
Yeah.
Or the depression recurring. At that point, you want to consider maybe we should go to that.
Yeah.
Or
So it does depend, but like I said, if it's, for instance, an adjustment disorder, if they had one, you know, when they first came in the service, right, and then went, you know, 10 years without having another one, like the system is still going to say like, oh, it's the same diagnosis, so it's a 2nd period, but it's really not, right? So the system's not smart enough to recognize that, but the people that review these things, especially when it goes to like MEB reviews and that kind of stuff, they do recognize it. So, all right, cool. Other questions? Yeah.
Can a different person that starts the review and a different person return back?
Yep. Yeah, I will say though, like they prefer it to be within the same specialty, right? So like primary care usually doesn't return people who are on behavioral health induced to duty, unless they have a specific recommendation from you. Like for instance, I had someone that I, for some reason, couldn't pick the right commuting authority because they were actually trying to like Pax River instead of us, and so I couldn't pick the right people in the system to return this person. So I worked with their primary care provider to do it, but then we had a conversation. It was explicitly documented that we wanted to do that. So, but yeah, you can do that. Because a lot of times, you know, somebody may have a Lindu like put on by the inpatient unit, right? And then you'll return them to duty later on as their outpatient provider. So yeah, it happens fairly frequently, actually. All right, so somebody had asked about returning people to duty. So this is how you do the return to duty form. So it's a 6100/6. So basically you get to their profile and then you will have a return of duty form button at the bottom. So you click that button and it'll bring up the 6100/6. So you basically complete the form. So what I would say is like, you do have the 1300/3 form on Lindu Smart, but it doesn't always populate correctly. And so most of the time I have to do it by on a PDF and then send that in as well. But you can fill out both of these and then put in the information, like same thing, pick the drop-down boxes, select the commuting authority, and then make sure you sign it and you get the little checkbox saying that it's signed, and then it'll go on. Okay, so the Lindu Smart help desk people are actually very helpful. So if you have any issues with Lindu Smart, if you have an issue where like somebody is stuck in the system and you're not able to like return them to duty, or you're having an issue like populating their forms, or they're not showing up correctly, whatever, if you email those guys, they're super helpful. Walter Reed has these Lindu coordinators, and then we mentioned Commander Del Sesto already. She's kind of the person who oversees almost all of the people within the Walter Reed system that are on Lindu from behavioral health. And at Fort Belvoir, we have a couple of awesome HMs that helped my sanity a whole lot. I don't know about the other Belvoir people, but like they were wonderful about pinging me when things needed to be done and when things needed to happen. So they're great as well. So I don't know anything about the people at Fort Meade, but these are the contacts that you need to know. All right, we've mentioned light duty chits, so I will talk about those now unless there are other questions about Lindu. I know it's kind of like I said, drinking from a fire hose, but it does get easier the more you do it.
And certain conditions will warrant Lindu. So like,
yeah,
you're not going to put someone with a personality disorder. It has to be potentially horrible conditions, or conditions maybe you're not sure that a person has.
Yeah.
But for instance, like a substance use disorder, when they go to residential treatment, I only see maybe one time a man actually wants someone to be on the Lindu status. Oftentimes, more than not, they're just TAD or temporary assignment to that residential treatment. They're not using a Lindu period for that. So.
Yeah. So I think at some point we will go, I think when we're doing the like ADCEP or MEB, like IDA's referral presentation, we'll talk about the like boardable versus not, like med boardable versus ADCEPable diagnoses. Because if the diagnosis is going to be administrative separation, like personality disorder, like ADHD, like substance use disorders, you really shouldn't be using a Lindu for those diagnoses.
Unless you think there are comorbidities attached to it, so if
Right.
there's BPD and major depression, sure, or you're not yet sure of the diagnosis, but one thing that I've also seen when someone goes on Lindu and then they're trying to be returned to duty is that maybe initially I've seen in their record, major depressive disorder, then it goes to unspecified, they're on Lindu, and then they get returned to duty, and the intent of the provider is to separate them for personality disorder. And I'm like, where did this come from? How is this going to be justified?
Yeah.
Convening a drug. We're not going to talk about assets. We also have to stand up on the assets as well. So if you're going to return something, one to do just be consistent and justify past either alleviation of condition.
Yeah, so for instance, like if you have somebody, because this happened to me recently, actually, you have somebody who came in to you like with a major depression diagnosis, but it's very clear early on that their symptoms are actually due to borderline personality disorder. You kind of have to roll back the med boardable diagnosis in your notes, right? Before, and attribute it strongly to the personality disorder diagnosis before you return them to duty and then ADCEP them, which is a pain in the butt, but it's doable.
Yeah, and it really depends. I mean, I would say if it was, and nothing to our colleagues who are outside of our specialty, but the board who meets for medical boards, they view us as the subject matter expert. So if it's family medicine, just maybe using MDD and not thinking that how much impact that may have, I might be able to further justify why it's maybe not major depressive disorder and it is something else major depressive disorder. But if it's coming from another colleague, and if there's a long kind of charting of it, not just like a one to QC situation, it might be better just to ask the board for that guidance and say, are they fit for full or not? And then once the board believes that fit for full, and you still suspect the personality disorder, then you can execute the ADCEP, because then you've covered yourself in all senses, and the health patient kind of, be advocate for that as well.
Yeah. I know that's probably clear as mud. But as we go through the other parts of this, like as we talk about the MEB stuff, as we talk about the ADCEP stuff, like it'll become like clearer and become a little easier kind of as we go through the process. And the farther you get in your training too, the more you'll do this. So, yeah.
And so, as an intern, big picture takeaway is that personality disorders get you an ADCEP.
Correct.
Psychiatric diagnosis get you an MEB potentially.
Most.
Okay.
Yes. If it's a acute adjustment disorder, no. If it's a chronic adjustment disorder, yes. So a chronic, like acute adjustment disorder would actually be an ADCEP diagnosis. ADHD is an ADCEP diagnosis too. Certain other ones, but we'll go through all that stuff in the other parts to this like series that we'll go through. All right. And there's a good, like, I don't know if we have it on our website or not. If we don't, there's a really good go-by that was made by Dr. Topoletto, who used to be at Fort Belvoir, has since like PCS from there, but there's really good go-by for like MEB diagnoses versus ADCEP diagnoses, as well as kind of going through the algorithm, like how do you get to a medical determination point for whether you send them to a med board or not, right? And it's got a really good kind of go-by for those things. So if we don't have that up, I'll look and we can always get that added to the website too. So that as we go through the rest of these things, then you guys have access to that too, because it kind of boils down to like, this is the most important stuff you need to know, like as I'm seeing patients and how do I go through this process in my brain.
I would say the big takeaway early on is just knowing that there are these buffer periods that exist for you not to feel rushed as a provider.
Yep.
That would be a big takeaway.
All right, so light duty chits. So here's one we'll talk about, like another issue. So 22-year-old female single, same kind of demographic information as the first one. Came in to the inpatient unit for suicidal ideation without intent or plan in the context of some work-related stressors and recent family member passing. After we get them stabilized and then, we're getting ready to discharge them, what do we do with this particular patient? So this is a little different. Like the last patient had an actual like suicide attempt. This patient has not and kind of only had vague, ideation no intent, no plan methods, right, in the context of very specific stressors. So this is where you would use something like a light duty recommendation. And these really don't have the same kind of tracking in the system, don't have the same kind of limitations, right, as far as, you know, overall career limitations, right, that the Lindu periods do. So this would be a situation where if you've got somebody like this coming out of the inpatient unit, yeah, you should probably still recommend some duty limitations to the command upon their discharge from the hospital, but you don't necessarily need to place the Lindu like we talked about, but you should still be giving some recommendations for duty limitations, because that's when you would use this. So here's the algorithm, again, from the same instruction that I put up before. So again, the ManMed chapter 18. Again, I will not go through this. So the light duty form is called it's on the same form as like SIQ chits, so sick in quarters chits. So again, we're talking about this, right? So will their duty limitations resolve within 90 days? If you think yes, or even if it's one of those situations where you've only seen them once, they've been hospitalized, you know, it didn't have a severe suicide attempt or they don't have like the high acuity symptoms, or you can say that it's due to a couple specific stressors, you're thinking like a more acute adjustment disorder situation, right? And you feel like they don't need to do a Lindu, but you still need to probably give them some limitations. This is a good place to do the light duty. So this is a period where obviously they'll report to work, but they do still have like some other recommended duty limitations. So the goal is to allow for a continued evaluation, right, and continued treatment, so that you can maybe, you know, the outpatient provider can make that determination, like, do we actually need a Lindu or not? And where is this person's trajectory going, say, coming out of the inpatient unit for one of these, I guess, like softer admissions. So common scenarios would be a new diagnosis, starting medications, adjusting medications, transitioning from a higher level of care. So like from inpatient to outpatient, residential, partial, intensive outpatient, that kind of stuff. Okay, so you can only do up to 3 of these in a row, right? So up to 90 days of a light duty before you automatically are going to need to put the Lindu in. All right, so this is the form, and we do have this form linked on the website. I did see it the other day. So it is on in one of the like drop downs, right? So that the website that they showed before, right, with the drop down boxes for like Navy Marines, there is one with this form attached. So what you need to do is obviously on this form, clearly annotate the restrictions, limitations, include the time period, which in this case would be 30 days, and then put that in the member's health record, and then you can give one to the chain of command as well. So again, like you give this like no deployments, no PCS, no CONUS assignments, TADY, TAD, ensure sleep, you know, that same very similar restrictions. But the main caveat to this is like, if you put them on a light duty, like, okay, fine, that's all well and good. The local command can follow those things. However, PERS does not have to follow that, and they're not going to know that you put them on a light duty. So like when they're looking through the system and say like this person's projected rotation date's coming up soon, they're up for orders, they need to move them somewhere else, the detailer is still going to be like, okay, well, this person's ready to go. It looks like, because in their system, they don't have any code attached to them. Looks like they're ready to go. So we're going to pluck them and recommend they move somewhere else or tag them for deployment, right? So if you really, my argument is like, if you really think that this person can't deploy, then you should probably be putting them on a Lindu as opposed to just a light duty. Having been somebody who did lots of deployment evaluations in my previous life, getting these people who are on light duty and their providers saying they can't deploy and then they get tagged for deployment, that just creates a whole big mess. And then somebody gets so what happens, just to give you guys an idea, somebody gets tagged for deployment, they come in for their screening. If they have a positive thing on their screening and the person who's screening them is like, oh wait, this guy really can't go, then somebody else gets tagged, but they get a shorter notification time. They get much less time to prepare for the deployment. It's a big pain in the butt, right? And so then it's screwing over the next guy basically because somebody didn't do their job by placing a Lindu when they needed to. Okay, so keep that in mind too. So again, like a light duty chit is just a recommendation. Commands don't have to follow them. PERS will not see it. It's not going to attach any code to them. So they can still be tagged for deployment. They can still be tagged to PCS somewhere. So again, like I said, for the most part, they do follow these recommendations. All right, this is the main thing for medical boards, right? So the ManMed Chapter 18. If you're having trouble sleeping and want some good reading, like I would fully recommend you pull this up and like try to read it and go to sleep, right? It's very lengthy. It hasn't been updated very recently. So the charts that are in there and with the algorithms that I showed before are nice, but otherwise it's a lot of information that you can also get to on the Lindu Smart page to put in a much better like package. So if you really want to read the ManMed, by all means, go for it. But you don't necessarily need to do that. The other things that we'll be talking about here in a little bit, right? Other than we'll talk about MEBs, so med wards, and then if you were looking for stuff about like administrative separations or the conditions not amounting to disability, so this is where like personality disorder diagnoses come in, ADHD comes in, that kind of stuff. Like that's also tracked through the Lindu system, but in a different pathway. If you want to know about that information, that's the website that you go to for that. All right, any other questions before we go on to like survey stuff? I know that was a lot of information over a very short period of time, but what do you guys want to know? Do you have any other questions before we do this? Oh, no, are there chat questions? Is there anything in the chat? Okay, it's just you guys trying to figure out like if things are working. Yeah.
The reason why this survey is really important is going to ask you comments before or after this presentation, and that'll help us adjust for future iterations. So thanks for doing this. That really should be.
Echoing Army's sentiments about the physical fitness piece, we as the health providers are often not. Two things we're not doing. We're not removing someone from working at all, because that's a common request that we hear. And then it's structure, productivity are good things, behavioral activation. These are good things to help someone who is maybe struggling with their mental health. Same thing with physical fitness. There's no, unless someone is catatonic or psychotic, or truly manic, there really is no limitations to someone performing physical fitness.
Matt, you have a question?
Yeah, I was just thinking about this in the context of somebody I've seen recently, where I didn't do anything before in terms of, recommendations for command. But if I have somebody that I'm seeing who is seeing, behavioral health, but, is not having trouble with to appointments and allowing for them to get their care, but like I am a little concerned about work being a stressor. Is that person a good candidate for light duty shit? And what can you imagine kind of like what limitations I would even put on their like duty, I guess? This is a foreman. I'm thinking in my case with foreman, who I just started seeing, and I'm not feeling great about how work is going, and that's a stressor. But what would I put in the light duty shit if you think?
Is it because like they feel like their command is a stressor, right? Like because they're requiring them to do certain things, or is it because like?
Not really. It's not really the command itself. It's just sort of like it's really difficult right now, and they're taking on a lot. They kind of expect a lot of them. Well, I guess it is. They expect a lot at work. They think the person previously was doing a lot of laterals, but now saying, I actually can't do that, which I totally recognize and agreement about. I'm just trying to think now. I thought the person is, this could be a situation.
So I guess like a couple questions for me is, do you think that they'll be able to come back to like full duties within a 90-day period, like within like, 90 days? Because their stressors will some of the stressors will kind of resolve over that period of time?
I think so.
Yeah,
Like, what would I put in the like shit? Like there's somebody who would work. So I say like patient shouldn't have, the person shouldn't have as many extra responsibilities, or is that appropriate though?
I mean, you could say things like, you don't recommend they take on like all of these additional collateral duties because of stressors. But a lot of times I'll talk to the chain of command, and sometimes I have patients where, they're specific, like say corpsmen are very common to come into us, both here at this hospital and at Port Belvoir. And sometimes the command will support by, if it's something specific within their clinic, right, that's really stressing them out. Or for instance, I had a patient who had, whose mom died of breast cancer, and they were assigned to the breast care clinic. And so like, that was not a great place for them anymore, right, for obvious reasons. And so I just talked to the chain of command and basically got them moved to a new clinic. And that was supported by the command and got them to a new place that's not as, triggering all the time for them because of that situation. And gave kind of basic recommendations for like making sure they, get enough sleep and all that kind of stuff. But doing something as simple as talking to the chain of command and seeing if they can then kind of accommodate some of those things, like moving them to a new clinic or something within the hospital system is good. And you can put that kind of stuff on your like light duty recommendation too.
I think it's a dual conversation. I
Yeah.
would say with patient, what is your understanding of what to do?
Yep.
And then will you allow me to speak? Because, you can contact with their CO, but their CO is gonna not have the visibility that's
Right.
like their LCO. So you might say, hey, in order for me to advocate for you, I maybe need to better understand, can I speak with your department head and see what we can arrange? Because you may not even need to like, the duty, like.
Right. Yep.
Dr. Walter Friedman said, it might be, moving you from the front of the ER to the back of the attic. It might be switching over to the dental department, like, there's a lot of different things. But then that gives you more data for if they're struggling there or in that new environment, you might say, oh, okay, we need to live here at this point.
Yeah, you can gain a lot of additional information if the command does those kind of things to accommodate and they're still having a lot of dysfunction. It kind of tells you like it's probably something different than just like that particular stressor.
Great, thank you.
Yeah. You guys asked great questions. Cool. Anything else? Yes, no?
All right, so anything after this, Kristen?
I don't think so. Is there anything else after this stuff? No, I think it's just
Okay, so this is your ticket out, but just, you guys they volunteered to come up here, do the research, share their experience, so kind of like, to thank them or give them a round of applause. You can all tell, it's really excited and talking with them, so thanks for kind of like telling them the slides together.
And also, thanks, Fisher, for helping us out. Absolutely. Running club in 15 minutes in the lobby. Thank you, everybody. Thank you.
All right.